Hello and good evening, everyone. Welcome to Immunisation Session 12, the rise of gonorrhoea and syphilis in women, brought to you by ACT Health and the Capital Health Network. In the spirit of reconciliation, the Capital Health Network and ACT Health acknowledges the traditional custodians of country throughout Australia and of the Canberra region, and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people here today. I am Dr. Leonie Harcourt, the GP advisor at Capital Health Network, and I'll be tonight's facilitator. I'm joined by Dr. Ingrid Elvey from the Canberra Sexual Health Centre and Drs. Alex Marmore and Therese Marfori from ACT Health. So, what would a webinar be without housekeeping? Here it goes. You've all been placed on mute. There'll be a chance for questions after the three presentations. Please type your questions into the Q&A chat box and we'll read them out at the end. And importantly for GPs attending tonight, as you know, we're at the pointy end of the triennium. So if you'd like some CPD points, we need you both to fill in the post-event evaluation survey and also please record your RACGP number. The slides will be all available to all attendees after the session, so we'll send out the links to that afterwards. So on with the show. I think tonight promises to be very interesting and there's lots of new information that we haven't been aware of, and we have three great presentations, so thank you to the presenters. The first presenter we have is Dr. Alex Marmore from ACT Health, who is speaking about the changing epidemiology of gonorrhoea and syphilis and the rise of congenital infections. Dr. Alex Marmore is a field epidemiologist and registered nurse. She's the surveillance coordinator for communicable disease control at ACT Health, and she is part of the team responsible for providing data for action on notifiable conditions in the ACT. Alex has a background in Aboriginal and Torres Strait Islander health and primary care. Thanks, Alex.
Thanks, Leonie. Can you see my slide?
Yep, I can see your slide.
Terrific, thank you. I'd also like to acknowledge that I'm speaking to you from what always was and always will be Ngunnawal land, this beautiful country where both I and my children were born. And thanks for the extra qualifications. I'm not a doctor, I'm an epidemiologist and registered nurse. I am part of the surveillance team at Communicable Disease Control, and we receive notifications of notifiable conditions and we investigate cases and outbreaks. And as you said, Leonie, we provide data for public health action. So in our team, we've got 3 dynamic and experienced public health nurses. We've got 2 epidemiology scholars and 3 epidemiologists, and we have our wonderful surveillance officer Melissa, who is often the first point of call if you call our CDC info line or if you email our CDC inbox. So thank you for the opportunity to speak to you today about the change in patterns of gonorrhoea and syphilis infection in the ACT. What I'm showing you here is a graph showing the total number of cases of gonorrhoea notified each quarter to ACT Health for the last 20 quarters, so from September 2017. So on the face of it, there's not really a pattern here, but if we look a little deeper in the data, we can see that there has been an important change. And surprise, surprise, that change occurred at about the end of March 2020. If we look at the average cases notified each quarter in the first 10 quarters up to the arrival of COVID, so shown with the dotted horizontal line there on the left, and compare it to the last 10 quarters or the average quarterly notification for the last 10 quarters, we can see that there has been a modest drop in the total number of gonorrhoea notifications. And from national data, we know that STI testing has been affected in the pandemic, so it's no surprise that there is a drop, and it may not represent a true reduction in infections in the community. When we look at the pale bars that I've added here, which are shows just the male cases, we can also see there's been a decrease in notifications from pre-COVID to since COVID arrived. And then here with the magenta bars, we've got the female cases notified and the average quarterly notifications. And we can see there's actually been an increase. While our numbers in the ACT are still small, this is a significant increase. And to just make that, just illustrate that a little further, this graph here shows the change in average quarterly, the percentage change in average quarterly notifications in the COVID era compared with the 10 quarters before March 2020. And so for total notifications, there's been that 10% reduction. So a small reduction that may be due to testing. There's been a 26% reduction in the total male cases. And when we look at males who report only having had same-sex partners, then it's an even greater reduction of 37%. And when we look at males who report opposite sex partners, there's been an increase. And for females, an 88% increase. This is obviously very concerning when we're considering the impacts on pregnancy and neonates, the potential there. We know from previous analyses of our data, our surveillance data, that females and heterosexual males are more likely to present to GPs than to a sexual health service for testing. So they're often in your domain. The cases that we're seeing in females are across the range of the reproductive ages from 15 to 50, and we're seeing infections in all body sites. So I'm sure Ingrid will cover this later, but this highlights the importance of taking a thorough sexual history and testing body sites based on that history. Also for gonorrhea, we've got emerging antimicrobial resistance to first-line treatments, which is of great concern. So it is important to collect a specimen for culture before treating with antibiotics. Some other changes that we've noticed, even just these last 2 weeks, we've had 5 cases amongst Aboriginal and Torres Strait Islander people when we would usually see about 20 in a year. We're also seeing in the last, in the COVID era, an increase in gonorrhea cases amongst people who have no regular sexual health service provider. So they present to emergency departments, they present to any GP they can get into. They may have insecure living arrangements, and they can be difficult to follow up. And we are sometimes losing cases to follow up despite best efforts of clinicians and our public health nurses. So if you have a patient who you think maybe has a pretty good chance of having an infection, you may want to consider presumptive treatment if you think it may be difficult to follow that person up. And also please consider an STI and bloodborne virus screen while you have them with you, because it can be difficult to track some people down again. So in response to this change in epidemiology at disease surveillance, in the last year we've instigated an online questionnaire for cases. So we want to understand what are the sexual networks in which this transmission is happening. How are people meeting their partners? How many partners are they having? What are the gender mixes, sexual orientations of the case? We would need to be able to target our interventions using the public health messaging and the platforms that will be most effective. So when we get an updated mobile number for each case, then we send an SMS to them. And so please do advise your patients that they will receive a message from us. And the first one looks like this, they get on the first day. It's a kind of a shot across the bow to say you're going to get a message tomorrow, and it gives them a chance to contact us if that's going to cause a problem for them to have something about that about gonorrhea on their phone. And then the following day, they will get this message with a link to a short online questionnaire. So please do let them know that that will happen. When our public health nurses speak to you, you do have an opportunity to say, please don't send it to them if there's some reason why it's not appropriate for it to be sent to your patient. So finishing with gonorrhea there and moving on to syphilis. This is quite a busy graph, but on the right-hand side, the bars show the notifications per quarter for non-Indigenous females in major Australian cities. And since January 2015, and the different colours show the different age groups. And the dotted lines at the bottom show the notification rates for each age group. And the left-hand side of the graph shows the same information, but for Aboriginal and Torres Strait Islander women. So you can see fewer cases, but much higher rates among that population. So we have seen a steady increase in syphilis amongst females in urban Australia over the last 5 years or so. And inevitably, this has led to an increase in cases of congenital syphilis across Australia. So this last bar here is just for Q1 of 2022. I know there have been more cases than that notified so far this year. We've had no cases of congenital syphilis in the ACT, but we have had syphilis cases who are pregnant. And we, fortunately, also in the ACT, we see very few cases of syphilis overall, and as I said, no congenital syphilis, but we do expect, based on the national data, to see an increase. So please do remember that syphilis testing, it's part of routine asymptomatic STI screen for all patients, regardless of whether they're female or male or their sexual orientation. And some pregnant women require additional testing under the guidelines. So here at CDC, we can help. We follow up with clinicians for every case to get that extra data and to ensure that cases are adequately treated. If you do need help with contact tracing, we can do that. We don't routinely do contact tracing, but we can, if it's we can give assistance if it's required, and we do often help. Our nurses do help contacting patients who are lost to follow up. So please do call us on our line if you've got any questions, and we can help. So thank you very much. That's the end for me.
That's great. Thank you very much, Alex. That was really clear. So next up, we've got Dr. Ingrid Elvey from the Canberra Sexual Health Centre, and she's going to speak to us about the new updates to the STI guidelines with respect to gonorrhea and syphilis, which seems very apt given the frightening stats that Alex just showed us, an 88% rise in infections in females. Dr. Ingrid Elvey is a recently fellow GP and now an advanced trainee in sexual health medicine. She has experience in general practice, sexual health, including HIV care, transgender health, reproductive health, and sexual assault care. She has worked in a range of urban general practice settings, including justice health, family planning, the forensic and medical sexual assault care service in Canberra, and the Therapeutic Goods Administration. In February 2022, Ingrid rejoined the team at the Canberra Sexual Health Centre as an advanced trainee. She has a special interest in women's health for people living with HIV. Thank you, Ingrid.
Thanks, Leonie. Can everybody hear me and see my slides okay?
Yep, we're all good.
Great. I think my blurb was a bit long now that I've heard you say that. Apologies. So as Leonie mentioned, my name's Ingrid. I'm an sexual health medicine trainee at the Canberra Sexual Health Centre. And I will be talking to you about the second and third objectives that we had for tonight, which were explaining new updates in the Australian STI guidelines, particularly in relationship to syphilis and gonorrhea, and to discuss the prevention and treatment of syphilis and gonorrhea and the clinical symptoms and sequelae of both illnesses. So essentially, I'll just be running through updates and recommendations to the guidelines, and I will be going through the clinical presentation and management of those. So there'll be lots of screenshots from the guidelines themselves. So the Australian STI management guidelines are designed for use in primary care. They provide evidence-based and up-to-date guidelines targeted for primary care in Australia. And recently, a major review was conducted of the guidelines between 2020 and 2022 by a group of clinical and non-clinical experts. There is actually a full summary of the recommendations and changes to the guidelines on the homepage of the STI guidelines website, which there's a link to in here. So the major recommendations which were made to gonorrhea, I've outlined here. So the first one was that really for all asymptomatic screening, HIV and syphilis should be recommended for everyone who you're doing asymptomatic screening for. So that hasn't always been in the guidelines. Previously, it was for higher risk populations, but it's actually really should be recommended for everybody. So if you're offering a chlamydia test on a urine, then please offer an HIV and syphilis test on bloods as well. They recommended more frequent syphilis testing in pregnancy and the antenatal period. This is a really important one, as Alex alluded to before when she was talking about syphilis rates, particularly in women and in pregnancy. I've already seen 2 pregnant women with syphilis this year in the ACT. So it's really important that that's included in preconception and antenatal screening. Gonorrhea treatment itself has remained unchanged. There is a recommendation that single dose oral ciprofloxacin is only used when we have confirmed susceptibility on culture. That's probably not as relevant for those of you who are working in general practice, because if we're at the point of using ciprofloxacin, then really the patient will most likely be referred to a sexual health centre. And then they also made a recommendation about inclusive language used throughout, particularly in transgender diverse people. So starting with asymptomatic screening, it's recommended that, so who do you test? You test anybody who's requesting an STI screen, even if they don't appear to you to be high risk for STIs. Often they might not be telling you something. So if somebody's requesting an STI test, generally best to just do an STI test for them. Anybody who's at increased risk of STIs, so people with new sexual partners, people travelling to or living in areas of higher prevalence in Australia or internationally, and anybody who has a known exposure to an STI or a history of an STI within the past 12 months. Also, anybody who is a member or has partners from priority subpopulations. So those are men who have sex with men, sex workers, pregnant people, and Aboriginal and Torres Strait Islander people, trans and gender diverse people as well. So when you're doing an asymptomatic screen, so somebody's come in and they've asked for asymptomatic screening, or you might have brought it up with them, and I'll go through that in a little bit when we talk about sexual history. But what tests are you actually doing? So most people, generally will be we'll get a urine test for chlamydia done. That's kind of the most common thing that we see. But essentially, if you're doing a full STI screen, you'll be doing blood for HIV and syphilis, as I mentioned before. And you might be including hepatitis B depending on that person's immunisation history. Most young people who grew up in Australia and went to high school, and Australian high schools would have been vaccinated for hepatitis B at school. But if there's, if it's unclear whether they've actually had those vaccinations or not, you can check their hepatitis B surface antibody. You can check them all, surface antigen and core antibody as well, to make sure that they are immune to hepatitis B. And of course, people who might be higher risk as well. And then gonorrhea and chlamydia testing. So most labs in the ACT at least will do both of those tests together. It's a dual test in the lab. So if you do order a chlamydia test, most likely a gonorrhea test will automatically be done. For men or for anybody without a vagina, a first pass urine is fine. And for anybody who, or for anybody that you can't do a vaginal swab for, they can't do a vaginal swab for some reason you can't do that, the urine is fine. But if you're, for people with vaginas, if the speculum examination is being done, then an endocervical swab Otherwise, a self-collected vaginal swab is good. So, sexual history taking. How do you approach that? Much easier for us in a sexual health centre because our patients are coming in expecting us to ask them questions about their sexual health. In general practice, that is a lot harder. And I certainly noticed that when I went from working in a sexual health centre to general practice. I found it was a lot more awkward talking to people about their sexual health than I was used to in the sexual health clinic. So sometimes it can be good to normalise STI screening. So, you know, telling your patients that you're offering STI screening for everybody under the age of 30 and that STI is very common, and then offering them a test and normalise it for them. You can use a hook, so, you know, explain to your patients that we are seeing a lot more syphilis and gonorrhoea recently in the ACT, and that, you know, these infections are easily treatable, but they can be serious, so would you like a test? Or you can incorporate it into an existing discussion or presentation. So you might have a patient coming in for a cervical screening test, for example, or contraception, and that could be a good time to bring it up. Of course, we're doing cervical screening a little bit less frequently than we used to, so probably better to bring it up a bit more than every 5 years, but that is one opportunity to do it. For some patients, answering invasive questions could be a barrier to initial testing, especially patients who are vulnerable to sexual shame and stigma. In this case, it's often better just offer basic STI screening and complete the full sexual health history and contact tracing if they test positive. It's not likely that, you know, this will happen for clinicians who are routinely offering STI testing and, you know, adopting non-judgmental body language and questions, but occasionally you do have patients that have a lot of difficulty talking about this sort of thing. Okay, so contact tracing. I'll mention that now, even though I haven't actually gone yet through presentation and management, but just to mention that contact tracing, as Alex was talking about as well, is a really important part of controlling HIV and STI transmission. In the guidelines now, there's an emphasis that it's part of our STI management and that it is the diagnosing clinician's responsibility rather than the public health unit to conduct contact tracing or help patients conduct contact tracing. So obviously, as Alex said, the public health unit is amazing at helping with that if you need it. But if you've ordered the test, it is your responsibility to talk to your patients about contact tracing. There is a contact tracing guideline through ASHM that you can actually look at that has a lot of detailed information about contact tracing. But in general, there's two ways that we do it. There's patient-initiated referral. We use this most commonly in the sexual health centre, otherwise we'd have too much work on our hands. So most of our patients will actually do their contact tracing themselves. So we talk to them about how far back they need to contact trace, and I'll mention that with management of gonorrhoea and syphilis. But essentially, you can some patients will often say, I've already told my partners to get a test, and that's great. But some patients need a little bit more of a nudge and help with their contact tracing. So there are 3 good websites that you can actually refer them to. These ones, so there's Let Them Know, Drama Down Under, and Better to Know, and each of these are targeted to particular populations. So Let Them Know for everyone. Drama Down Under is targeted a bit more for men who have sex with other men, and Better to Know is targeted more for Aboriginal and Torres Strait Islander people. These websites are really good. They generally require a minimum of a phone number for contacts. So if a patient's met somebody on Tinder or something like that online and they have a phone number for them, but that's it, and they really don't want to talk to them because it was just one-off, then they can actually put their phone number into one of these websites, select the STI in question, and then and that's it. They'll receive an anonymous text message to say that they've been in contact with chlamydia, for example, or gonorrhoea or syphilis, and that they should get a test. So that's really helpful resource for patients if they need help, but otherwise they can simply contact their partners and tell them they need to come in for testing and or treatment depending on the infection. Provider-initiated referral, we tend to use more for HIV, new HIV infections, where, you know, we really want, you know, even more important that we contact all partners. But other situations sometimes as well, syphilis in pregnancy, concerns around domestic violence and sexual assault. So the slightly more complex cases, I suppose. And that's really when, as the provider, we're actually doing the contact tracing. So we might use a form to take a list of our patients' contacts and their phone numbers, and we actually go through them ourselves and contact them. Other CAPs can also help with this as well. Okay, so I might move on now to talk about gonorrhea. So the main points about gonorrhea, I'm just kind of listing at the beginning here, and then I'll go through in a little bit more detail. And these are the main summary points from the guidelines. So for gonorrhea, pharyngeal swabs, so throat swabs are now recommended for all people with multiple sexual partners, including MSM and sex workers. Actually, at the Canberra Sexual Health Centre, we are routinely offering gonorrhea throat testing for men who have sex with men and sex workers. And people who might identify that they're higher risk for some reason. It might be a female who has bisexual male partners, for example. We're actually not, interestingly, offering it to absolutely everybody with multiple sexual partners. So this was an interesting one for me to see as one of the recent recommendations in the guideline. Anal rectal swabs are recommended for anyone who has anal sex and for all men who have sex with other men. And gonococcal culture should always be collected at the site of infection before antibiotics are administered. So this is, Alex mentioned this one as well. But so that swab should be collected before you start antibiotics, but you shouldn't delay treatment while you're waiting for the results of those. So it's fine to treat them and take the swab on the same day. And then if there's any issues with susceptibility to antibiotics, then you can deal with that at that point, but try and take it before antibiotics are started. So clinical presentation of gonorrhea. There are lots of asymptomatic cases, just like with chlamydia. Anal and pharyngeal gonorrhea are usually asymptomatic in most people. Vaginal gonorrhea is often asymptomatic, about 80% of cases. And urethral gonorrhea, so penile urethral gonorrhea, is almost always symptomatic, and that's usually urethral discharge. And it's usually quite significant urethral discharge as well. So, you know, they'll come in, and if you examine them, they'll usually quite obviously be discharged from the urethra. They can also have dysuria, vaginal discharge, and so those are the common ones. Then, of course, they can have painful sex with cervicitis in females, and it can cause conjunctivitis as well. That would be something that you would be definitely referring. And anorectal symptoms are common as well, and that can be irritation, discharge, pain when passing bowel motions. They can even get, you know, diarrhea from having gonorrhea. So it can be quite non-specific symptoms as well. Untreated gonorrhea most commonly could cause PID or epididymoorchitis. It can cause prostatitis, but that's quite rare. And then there's some other complications here that I have to admit I have never seen. Never seen disseminated disease, Bartholin gland abscesses. That's definitely possible. And meningitis, endocarditis, that would be quite rare. Okay, and I didn't actually put, I did for syphilis, but for this one I didn't put pictures in. Really, the type of pictures that you would see, you can look up the STI Atlas, which is linked to on the guidelines, which is really useful. Mostly it's pictures of, you know, greeny yellow, purulent urethral discharge, and cervicitis seminal speculum exam. All right, this is a bit of a busy slide. So these are essentially screenshots from the guidelines. So this is what you'll see if you're following the guidelines for your diagnosis and management. So mentioned already, always take the culture samples before treating if you can, to check for antimicrobial sensitivity. So diagnosis of gonorrhea, it depends on your patient. So for anybody who has who doesn't have a vagina, or you can't collect an endocycal swab or a vaginal swab, then a first pass urine is fine. Bearing in mind that for your patients who are men who have sex with other men, please make sure that even if they're coming in with symptoms, you're also including an anal swab and a throat swab as well. Even if they're asymptomatic at those sites, you will very rarely have patients, for MSM patients, that are only having insertive anal sex. So always offer those other sites as well. If the patient has actually come in, so for asymptomatic screening, then it's just your PCR test. But if they have come in with symptoms, so if they have urethral discharge, you can also take a culture swab as well of the discharge itself, and that's really helpful to do that at the time of diagnosing. You don't have to go back and collect one later. Of course, you can do a clinician-collected endocervical swab if you're doing a speculum exam as part of the presentation. You would certainly be doing that for any women that have PID symptoms. Self-collected vaginal swabs for people with vaginas for asymptomatic screening is absolutely fine. But if they do have, for example, it's a good idea to also collect a culture swab as well. Anorectal swabs, this probably should say self-collected here, I think. Oh, they've specified there. So collected if they're asymptomatic. Potentially if they have proctitis, you might be collecting this swab yourself. But an anorectal PCR swab for all men who have sex with men, like was mentioned earlier, and any patients with anorectal. Again, if they're symptomatic, also collecting who have sex with men and anybody else with multiple sexual partners. All right, so that's our diagnosis. Management of gonorrhea. So as I mentioned earlier, the management actually hasn't changed. One thing I will mention is that if you have diagnosed gonorrhea in general practice, sometimes it is a little bit hard to access the treatment for gonorrhea. So many GP clinics will actually stock ceftriaxone, some don't though. And because they have to have an injection, it's not the easiest thing to just send the patient off to a pharmacy. They can go and get it and come back to you, but don't hesitate to refer patients for treatment of gonorrhea. It's completely reasonable. So for uncomplicated genital and anorectal infections, the treatment for gonorrhea is 500 milligrams of ceftriaxone, which is a powder diluted in 2 mils of 1% lidocaine without adrenaline, and also azithromycin 1 gram as a stat dose, so two 500 milligram tablets taken at the same time. The azithromycin, so the main treatment is your ceftriaxone. Giving the azithromycin as well helps to create a pharmacological barrier for the development of more widespread resistance to treatment. However, if for some reason the azithromycin can't be taken, it is most likely that ceftriaxone will treat the infection, but don't only give ceftriaxone. So you are meant to give both together. I had a patient, I had some advice from requested from a GP a while ago who'd given their patient both of these, and the patient kept vomiting the azithromycin. She was wondering what to do because he'd given it to her twice and she kept vomiting it. So in that case, you know, I said, no, don't keep giving them azithromycin, just make sure that a test of cure is done, which is recommended a couple of weeks after they've had their treatment. Throat infection is slightly different in that you actually give 2 grams of azithromycin. This is because essentially the throat gonorrhea is more likely potentially to be resistant. We actually don't have much resistant gonorrhea in the ACT. Most resistant, multi-drug resistant gonorrhea has come from overseas. There might have been very few cases in potentially Sydney or Melbourne, but generally in the ACT, we're not seeing resistant gonorrhea. So for the most part, it's going to be Ketrax and azithromycin. Conjunctivitis is the same treatment, but if you had a patient with gonococcal conjunctivitis, you'd be referring them as well to see an ophthalmologist for an urgent appointment, but the treatment is the same as for genital and anorectal infections. A few other points about treatment. Yes, I did have a point here, really just about sharing of antimicrobial resistant genetic material between bacteria and reduced drug penetration to pharyngeal mucosa makes the most likely site of treatment failure. So that's why the azithromycin is 2 grams. If a patient with a vagina has an IUD in place, you treat as recommended and you leave the IUD in place. So generally we try not to take out IUDs if we don't have to when they're doing the job that they need to. So most of the time we'll keep that in place, particularly for uncomplicated gonorrhea. Okay, so contact tracing of gonorrhea is very important, as we mentioned before. Generally, you contact trace back to a minimum of 2 months, and it is us as the diagnosing clinician who's responsible for initiating and documenting a discussion about that. It's also important to let patients know not to have unprotected sex, again, with any partners they've had in the last 2 months until they know that they've been tested plus or minus treatment. All right, so that's gonorrhea. So I might move on to syphilis now. The main point about syphilis in terms of the guideline update, as Alex talked about, there's quite concerning increasing infection rates in heterosexuals and during pregnancy, as well as outbreaks in remote areas. It's recommended that syphilis be included whenever STI testing is offered in all populations, as I mentioned before, and particular emphasis on antenatal screening with recommendation to test multiple times during pregnancy. Patient that I had not too long ago who had syphilis in pregnancy actually had preconception bloods done earlier in the year that included an HIV test and hepatitis test, but it didn't include a syphilis test, which was such a shame because she most likely had latent syphilis, so it could have been picked up well before a planned pregnancy, but it was actually picked up in the first antenatal bloods. So anytime you're doing HIV or hepatitis screening, always do syphilis as well, especially in antenatal care. All right, so clinical presentation. This one is pretty complex. With syphilis, it can present in multiple different ways. About 50% of people won't have symptoms at all, and they will just be diagnosed on routine screening on a blood test. Very complex interpretation of syphilis serology, which I'm not going to go into lots of detail or we'll be here all night. But it's often good to have previous test results to compare to, particularly from the same lab, but that's not always possible because there are differences from lab to lab. Syphilis can mimic many other conditions. It's the great masquerader. And I'll show you a few pictures of syphilis rashes in a little bit to show you the range of presentations there can be. They mention here syphilis testing all patients with unexplained symptoms. So Yeah, so sometimes it can be something as innocent as diarrhea that hasn't been explained by anything else. So syphilis has three main stages that you might have heard of. So early infectious syphilis, which includes primary, secondary, and early latent infection. And the classification of this is really that the infection is acquired in the previous within the previous 2 years. So they don't have so they have evidence of negative serology within the last 2 years. And then latent syphilis, most likely asymptomatic, and it's an infection that was acquired more than two years before diagnosis, or if it's unknown, so they actually don't have previous syphilis testing at all, for example. Tertiary or late symptomatic syphilis can present with neurological, cardiovascular, and gummative complications. Gummative complications are those nasty kind of skin sores and lesions with deterioration of skin tissues that you would have seen nasty pictures of if you Google syphilis. All right, so this is quite a busy slide from the guidelines. Primary syphilis most commonly will present with a genital, anal, or oral ulcer, large, generally painless ulcer called a chancre. It's not always painless, but more often than not, it is. I'll show you a picture of these in a bit, but generally they're quite large, more than a 10-cent piece usually. They have an indurated red edge to them and a firm base. So they're large. They're much larger usually than syphilis, than herpes ulcers. So they look quite different and they're usually much less painful. There might be multiple ulcers, and it is important to have a low threshold for testing in other types of ulceration as well. So even maybe if somebody's coming in with likely herpes, potentially you might be testing that for syphilis as well. Sometimes patients don't notice the ulcers if they're anal ulcers or if they're on the cervix. I have to admit I have not seen any chancres on the cervix before, but they wouldn't notice those if they're they're painless, and then mouth lesions as well. Incubation period is usually about 3 weeks. Often lymph nodes are enlarged, rubbery, non-tender. And usually these ulcers with primary syphilis will go away spontaneously, even if there's no treatment. Primary syphilis is highly infectious to sexual contact and during pregnancy as well to the fetus. Secondary syphilis usually occurs more than 6 weeks after infection, and it's usually characterized by systemic signs and symptoms. So they might present with fever, malaise, headache, lymphadenopathy. Most commonly, though, they present with generalized rash. So it's usually a maculopapular rash that could easily look like a drug eruption, psoriasis rosacea, or guttate psoriasis. It usually is, it will include the soles of the feet and hands as well. And they can sometimes have alopecia, they can have mucus patches, and condylomata lata, which I may have a picture of, looks a bit like warts, and it's usually in the anogenital region. They can get neurological signs, so visual changes, tinnitus, deafness, cranial nerve palsy, meningitis. These symptoms would indicate potentially that there's neurosyphilis, so that can happen in secondary syphilis as well. I have had a patient with sudden hearing loss that was thought to have neurosyphilis, and those patients require to be referred to ED usually for IV therapy. Incubation period for syphilis, secondary syphilis, as I said, is usually up to 6 weeks. And again, symptoms slowly resolve after a few weeks, but could come back later if not treated. Highly infectious as well to sexual contact and in pregnancy. Okay, last slide about presentation of syphilis. So latent early and late latent syphilis. So early latent syphilis, this one's a little bit confusing. Usually an absence of symptoms, but acquired within the last 2 years. So it's a bit hard to tell the difference between early latent syphilis and asymptomatic primary syphilis, mainly just whether or not they've had a negative test within the last 2 years or not. So that one's a little bit trickier. And this is something that really you would not be expected. For the most part, if you're diagnosing syphilis in general practice, you will be referring these patients. So don't stress too much about this. And I'll explain part of the reason why that is in terms of access to treatment for syphilis. Late latent syphilis is more than 2 years duration. So they don't have a negative test within the last 2 years. They're no longer infectious at this point. So they might have been exposed to syphilis, 10 plus years ago, and they have late latent syphilis. It's never been picked up, but they're not infectious. They're sexual partners. Interestingly and importantly, it can still be transmitted through pregnancy to the fetus. It is my understanding of this, though, that it is slightly lower risk than primary and early latent and secondary syphilis. Tertiary syphilis, another very complex one. This is when years later, about 1/3 of cases, if not treated, can actually develop into tertiary syphilis. Not very common, but they can actually get cardiovascular disease, neurological disease, and these destructive skin lesions or gummas. All right, sorry, I should have given you a warning for this slide. So these are some pictures of primary syphilis. As you can see, so we've got 3 penile ulcers there. This third picture, realize you can't see my, there you go, you can now. This third picture here is pretty classic looking chancre. These are also chancres, but you can see there's a little bit of a variation. That first one, you would almost look at that and think that it looks like a herpes ulcer. That's not a very good photo, but I think that's showing a chancre as well. This is an anal chancre that you can see there. Again, not super easy to differentiate from other ulcers, but this one definitely, you can see that indurated sort of raised edge there, and they're usually quite firm underneath if you palpate them. There's a few more photos here. So this, sorry, this should say, I think this should say secondary syphilis rashes underneath there. But this is a common rash that you see, these first two in secondary syphilis, all of those 4. You can see on the palm of the hand there. So these are pretty kind of, non-specific looking rashes really in secondary syphilis. And just some other ones, variations that you can get on here. This one, I think, is an example of condylar Martha, which I mentioned before, which is almost a bit wart-like, but sometimes that can actually look very wart-like. I don't have a good example of that one here. Okay, get rid of the nasty pictures. So complications of syphilis. So I mentioned before, early neurosyphilis, so it can affect the central nervous system, visual changes, hearing loss, those other things I mentioned before. So those people require referral for intravenous therapy. And of course, in pregnancy, it can cause congenital syphilis, which we really want to try and avoid. All right, diagnosis of syphilis. So ACTION has a lot of really wonderful decision-making tools, including ones for syphilis, so you can always have a look at that. But it's a combination of serology, PCR swab of a chancre, for example, history and clinical assessment. So if there's a suspicion of primary syphilis, but serology is negative, which is not uncommon, you really want to be, so that would be patients that are coming in with primary syphilis symptoms, so a chancre, for example. You really want to take a PCR swab. It's usually a flocked swab, of the, actually it's not a block swab anymore, don't take my word for that, but you can check with your local lab, but a PCR swab of the chancre, which will actually come back positive much earlier usually than serology does. So serology can have up to about a 3-month window period for becoming positive. There are point of care testing as well that are sometimes used, particularly in rural and remote areas. So on the blood is syphilis serology that you're asking for, and they will test the syphilis antibody. There's a few different antibody tests. I'm not going to go into all the tests for that, but generally there'll be an antibody test, and then if that's positive, they will do a second test called an RPR, and that tells us whether it's a new syphilis infection or not. It helps to differentiate between new infections and past positive, so positive antibodies from past infections. Syphilis antibodies usually remain positive for life after a syphilis infection. They can sometimes become negative, but generally they remain positive. And then a PCR swab of a chancre if there is one. In terms of your indications for testing, obviously if patients are symptomatic like that, or if you're doing asymptomatic STI screening as well. And in pregnancy. Okay. So management of syphilis. This is very tricky out in general practice. Again, there are some clinics that will have the benzathine penicillin available for syphilis treatment, but it is pretty hard to access this, at least here in Canberra anyway, through pharmacies. So I had a patient a few years back, 18-year-old heterosexual guy who was tested positive for syphilis through his GP and was provided a script for the treatment. And he tried to get it once from a pharmacy that didn't stock it, and then he just gave up and didn't have treatment until probably a couple of months later when he was chased up by public health, unfortunately after having unprotected sex with about 5 or 6 young women in the meantime. So very tricky to access benzathine penicillin in the community. It is completely reasonable to refer patients to the Sexual Health Centre for syphilis treatment. And if you do that, please send along the blood tests or any of the tests that you've done so we can see those. We always repeat the syphilis RPR on the day of treatment. That's because it doubles usually around every 5 to 7 days. So by the time somebody is referred in, sometimes it's been almost a week after the test has been done. And so that RPR titer in the blood can have doubled or, quadrupled. And then we actually use the RPR 3 months later to check response to treatment. So we always recheck it on the day of treatment so that we actually have an accurate number to compare to later, because we're looking for a 2-fold decrease in the RPR to know that the treatment's been successful. So in terms of treatment, early syphilis, we treat with benzathine penicillin, which is 2.4 million units in a 1.8 gram prepackaged vial, intramuscular, and that's usually divided into 2 vials, sorry. So each one is 900 milligrams or 1.2 million units. So they have one on each side. Usually it's a gluteal injection or a ventrogluteal injection is actually the recommendation now. If it's latent syphilis or syphilis of unknown duration, they have to have this treatment repeated 2 more times after that, so weekly for 3 weeks. Not the most pleasant treatment ever, but generally people seem to tolerate it okay. It is important to warn patients about the Yarish Herxheimer reaction, which I can never say. I usually call it the JH reaction, which is a really common reaction to treatment in patients with primary and secondary syphilis. It occurs about 6 to 12 hours after they commence treatment, and it's basically like the nasty kind of flu-like symptoms, so fever, headache, malaise, rigors, and joint pain. And it can last a few hours, but then it just resolves. So just to warn patients that this could happen, and that if it does happen, it is a quite common and normal response to treatment. It's due to the rapid breakdown of the bacteria and the releasing of toxins into the system. Any patient that has complicated syphilis, or really most patients with syphilis in general, do need to be referred. But certainly if you have a patient who tests positive syphilis and they have suspected tertiary disease or neurological symptoms, they really should be referred. Please speak to us first, but they most likely will need to be referred to the ED to be seen by infectious disease. Again, pregnant people who test positive for syphilis absolutely need to be referred. And in many cases, if the infection happens at greater than 20 weeks gestation, I'll need fetal monitoring as well, potentially. It's really important with syphilis, and I think I've got that on my next slide, in terms of contact tracing, but particularly, so if you have somebody in pregnancy who tests positive for syphilis, you absolutely must get their partner treated if they have a regular partner, to make sure that they're not re-exposed to syphilis again during their pregnancy. So you'd be testing both the mother and the partner as well. Allergies to penicillin can sometimes be an issue in syphilis treatment. So if they have an uncomplicated early syphilis and there is a penicillin allergy, there is an alternative, but that would always be done through the specialist service. So through the sexual health centre, we can give doxycycline orally as a replacement, but it's not as good as them seeing penicillin. Sometimes patients are actually referred to immunology to have desensitization. And then they end up having to see penicillin anyway. All right, I won't go on further with that because I think that's right, I'm almost at the end. I think I'm running out of time. So contact tracing syphilis, very important, as I've discussed already. We treat all contacts with syphilis. So unlike with gonorrhea, where potentially we might just be, we won't necessarily presumptively treat contacts with gonorrhea, but with syphilis, we pretty much always do. So any sexual contact for primary syphilis within the last 3 months, that should come in for treatment. Secondary syphilis, that's increased to 6 months, or since the last negative test. And for early latent, it's generally 12 months, or since the most recent negative test. And for late latent, you would test and treat the current partner, or any partners, usually within the last 12 months, but most definitely their regular partner needs treatment. Even though at that point, with late latent, they might not be, they most likely won't be infectious. And the treatment that all contacts should have is the same. It's benzathine penicillin as a stat dose in that divided dosing. There is more information, like I mentioned before, in the Australian contact tracing guidelines, which are really helpful. That is the end of my part of the talk. I raced through that. So I could go on forever about syphilis and gonorrhea, but that's kind of the basics, and most of that is outlined quite nicely in the guidelines, but just a few updates there. I was going to make a little plug really quickly for just reminding you all that doxycycline is the first line treatment for all chlamydia infections. We still get quite a lot of people referred in who've had azithromycin used for treatment for gonorrhea, for chlamydia. That wasn't the focus of this talk, but I promised my boss I'd remind everybody to use doxycycline to treat chlamydia. That's it. That's the end of my section of the talk. I'm sorry if I went a little over time.
That was absolutely very interesting. Thank you so much, Ingrid. And don't forget, everyone, if you've got any questions, please type them into the Q&A box. I've certainly got a few questions. So next up, and our last speaker for the night is Dr. Therese Marfori from ACT Health, and she'll be updating us on the recent changes to monkeypox vaccination guidelines. Dr. Therese is a public health physician at ACT Health with experience in emergency responses, health protection and research, and she's supporting the public health response to monkeypox within the ACT Health. So thanks very much, Therese.
Thank you. Unmute myself. I'm just checking that you can see my screen.
Yes, that's great. Thanks.
Great. So thanks, Leonie, for the introduction. I'd just like to start by acknowledging the traditional custodians of the land on which we're meeting, the Ngunnawal people, and express my respect for their continuing culture and the contribution they make to Canberra. So as a bit of a change in the topic, I'm just giving a quick update on monkeypox. And hot off the press, there's actually a new name for monkeypox called Mpox, which will be the synonym for monkeypox. So both names will be used for the next year while monkeypox is phased out, and WHO announced that today. And the reason for the change was that there were concerns raised about racist and stigmatizing terminology with the old name. So just a quick recap of monkeypox. Or Mpox. It's an infectious disease caused by the monkeypox virus, and this virus is very closely related to the variola virus or smallpox virus. Symptoms can include a rash or pimple-like lesions, which can occur anywhere on the body, but has been most particularly seen in the genital, anus, or buttocks regions. And typically, the lesions change in morphology, so generally starting as more of a flat red rash that develops into pustules, which then form crusts or scads and fall off. And you can see a bit of that progression in those images there. It can also cause ulcers or lesions in the mouth, and other symptoms include fever, headaches, muscle aches, back pain, swollen lymph nodes, and that can occur before the rash or lesions develop. So it's most commonly transmitted through direct skin-to-skin contact with someone who has symptoms, so who generally has that rash or lesions. And less commonly, it can be transmitted through direct contact with contaminated objects like bedding, towels, and clothes, but that's believed to be less common. Symptoms usually begin about 7 to 14 days after exposure, and this can be as short as a few days or as long as 21 days. And most people with Mpox recover without specific treatment within a few weeks, but there is a risk of severe disease and complications such as secondary infection, sepsis, and encephalitis, which is increased in people who are immunocompromised, young people, and pregnant women. And some people do need support in hospital with antiviral medication. So you might remember back in May, Mpox came onto the scene when we saw multiple countries in Europe and North America where the illness wasn't previously really seen. It was mostly only seen in Western and Central Africa. And as I mentioned, transmission generally occurs through direct skin-to-skin contact with someone who has symptoms. And most of the transmission with this outbreak has been driven through close physical contact during sexual encounters, which was previously seen as more of a minor route. It is also believed that there may be transmission directly through bodily fluids, such as semen. And the ongoing outbreak has largely occurred within networks of men who have sex with men, and globally more than 95% of cases are men, and more than 80% are believed to be men who have sex with men. So you can see in that epi curve in the graphic on the screen that the peak of the outbreak occurred during the Northern Hemisphere summer. And it was believed to have started from World Pride events during that time, as well as traveled to the Northern Hemisphere summer. Generally with this outbreak, the severity has been low with few reported hospitalizations and deaths. And that reflects the fact that it's the less severe clade that has been circulating. And so in Australia,
hello everyone, we're still working on Therese, so we thought maybe we might use this opportunity to ask some of the questions that we've already received. So are you there, Ingrid and Alex?
Yes, I'm here. Would you like me to put my camera back on?
Yes.
Yep. So I'll just start off with the first question, and it's, can you explain the legality of prescribing STI treatment to the partner or partners of a positive case when you haven't seen them as a patient and they're not a practice patient? So maybe Ingrid?
Yeah, sure. So that's an interesting question. And certainly this, I think you're probably asking not for syphilis or gonorrhea, because we can't really get a partner to administer that treatment anyway. So this would more likely be in the case, for example, for chlamydia. We actually had a program through the Canberra Sexual Health Centre, which was called patient-delivered partner therapy. I think that's what it was called, where we actually did provide treatment for chlamydia to our index patient. So a person who we've tested positive for chlamydia, in order for them to provide it to their regular partner, for example. But we did that with a phone call. So I suppose a telehealth appointment really with their partner, because of course, if we're prescribing medication, we really have to be able to talk to the partner to check allergies and all of that sort of thing. So I can't really explain it from a legal point of view. I think if you are confident that, if you're happy that you're prescribing something to somebody that you can be certain doesn't have antibiotic allergies, for example, and that you can give brief counselling for side effects and, precautions for the antibiotics, then it's fine. But if you haven't seen them as a patient ever, and they're not a practice patient, and you don't have that information about them, I don't think it's a good idea to rely on information from the partner. Just from, I guess, a prescribing point of view, might not be safe to do that.
That's great. Thanks, Ingrid. So there's another question, and I think it was typed in possibly before you talked about the RPR, and it was about the duration of someone's syphilis infection. So if you have no idea when the patient acquired syphilis, should the patient have an LP to exclude neurosyphilis?
Good question as well. We don't refer patients to LPs unless we have a clinical suspicion that they might have neurosyphilis. So if they do have any of those central nervous system symptoms, then you might be worried about that, and you might refer them for a lumbar puncture. But if they're not presenting with neurological symptoms, and you don't have a previous negative syphilis test, you'd be treating them as latent syphilis. So you'd be giving them their benzene penicillin weekly for 3 weeks. But yeah, you don't have to refer them for a lumbar puncture unless you have clinical suspicion of neurosyphilis. Hopefully that answers that question. It is quite complex though. There's certainly more complicated cases sometimes, maybe in patients who are immunosuppressed, where a lumbar puncture might be indicated, but not usually if there's no clinical suspicion. If as well you actually do have a patient coming in with a chancre, or their test result shows a very high RPR, so the RPR might come back as 128, 256, etc. Can't do the maths in my head. Then you actually probably have a stronger suspicion that it is actually a recent infection if you have a positive RPR like that. Sometimes if it's an older infection, so the RPR will go up at the beginning and then it will slowly go back down again. So, if somebody has an RPR of 4, 8 or 2, it's a bit, it's a bit harder to know if that's an early infection or the end of an old infection. It is quite complicated. But, hopefully that answers your question.
That's great. Thanks. So another question about fomite spread. So, you know, we've had a lot of talk about fomite spread with monkeypox or with COVID. So what's the kind of fomite risk with gonorrhea and with syphilis?
That's a good question. I'm not sure if I can answer that very well. I'm not aware of fomite transmission for gonorrhea and syphilis. Personally, I don't know, Alex, if you have any extra information about that.
No, it's not something I've come across in the literature. Yeah.
Really, risk for gonorrhea and syphilis is through sexual contact. Otherwise, I think we'd probably see a lot more of it than we do.
Right. Yeah. And so conjunctivitis and tonsillitis are very, very common GP presentations. When should we kind of go the extra mile and think, well, this might not be a simple case of conjunctivitis or tonsillitis, because we don't always swab everybody. So I guess Alex talked a lot about taking a good history, but sometimes, you know, you just take things at face value.
Yeah, that's a good question. And certainly plenty of pharyngeal gonorrhea is probably often missed and treated as tonsillitis, possibly. So definitely, you know, your thorough history is going to give you a bit of extra information. So if you have a patient presenting to you who is a male patient who has sex with other men, and you know that they're higher risk for gonorrhea and they present with a sore throat, then and they haven't had a recent STI screen, then you might want to, you know, do both your culture swab and a PCR, and then hopefully you'll find out from the start. But it can present really in a really similar way to tonsillitis, to be honest. You're probably less likely to have that really typical spotty tonsils with pus on them with gonorrhea. So, you know, if their risk is low and they're presenting like tonsillitis, most likely they have tonsillitis. But yeah, it depends on the patient population a little bit, I think. And with conjunctivitis, again, it depends on their sexual history. Congenital or, you know, like infant conjunctivitis, gonorrhea that's actually transmitted through birth is a bit of a different scenario. Usually that's when there's a known case of vaginal gonorrhea in the mother, you know, right around birth. And that's a little bit different. But other people who are coming in with conjunctivitis, if you're suspecting bacterial conjunctivitis and they have a higher sexual risk, then you might consider to do a PCR swab of the conjunctiva as well, and you'd find out. But presentation-wise, yeah, it presents like bacterial conjunctivitis, probably a bit worse than most bacterial conjunctivitis. I have to admit, we don't see it a lot because I think sometimes we get referred patients with conjunctivitis who've had the testing done elsewhere and then they've been sent in. But it just really depends on the risk of the person that you're seeing, really.
So I've got another question. Are you aware of issues with this is to do, I know you weren't going to talk about chlamydia, but we've got will you answer a question on chlamydia? So we've got, are you aware of any issues with compliance using doxycycline for treatment of chlamydia rather than a stat dose of azithromycin?
That's a good question. Thank you, Claire. Nice to see you online. That's a good question. I think if you have particular concern about compliance, it's, you know, azithromycin is still the alternative treatment. If you had big concerns about your patient taking doxycycline for a week, then absolutely treat with azithromycin. You know, the only antibiotics that's going to work is the one that the patient takes. So, you know, certainly if there are compliance issues, I think that's reasonable. It's the alternative anyway. So it's fine. If you are, however, treating rectal chlamydia with azithromycin, they actually need 2 doses. So, and the guidelines have just recently changed on that as well. So they have their first dose of 1 gram of azithromycin, and then I think it's 24 hours later they have their second dose. It used to be a week. Double check that because I might have said that wrong. I think it is 24 hours later they have the second dose for rectal chlamydia. But yeah, quite reasonable if you're worried about compliance issues to use azithromycin.
Lovely, thank you. And that was very good. Thanks, Ingrid. Thanks, Alex. So we've just got Therese back on, so we'll swap over to Therese. Welcome back, Therese.
So all of the cases in Australia have actually been in men, and most of the cases have been in Victoria and New South Wales, and overall reflecting the global trends, there has been a decline in cases in recent months. So in terms of the vaccines, there's 2. There's a second generation one called ACAM. The other one is called Jynneos, which is a preferred vaccine due to the fact that there's fewer contraindications and a better safety profile. It's also a lot easier to administer. So it's a live attenuated non-replicating vaccine, and it is safe to use in people who are immunocompromised. The most common adverse event is a local injection site reaction, and 2 doses at least 28 days apart is required for greatest protection. So in addition to pre-exposure prophylaxis, it can also be used as post-exposure prophylaxis. So if someone has monkeypox, or if they've been exposed to someone with monkeypox, ACT Health does a risk assessment of the contacts, and they determine the risk and any required management. So those who are at highest risk of becoming unwell with mpox, they'll be offered vaccination as part of post-exposure prophylaxis. And that needs to be given as soon as possible after their first exposure. Even if it happens between 4 to 14 days, it's still anticipated to attenuate disease. The other key thing is that it previously was only given subcutaneously, but recently the Australian Technical Advisory Group of Immunisation updated their advice to allow for intradermal administration, which is a little bit more tricky than giving it subcut, but it does mean that we can give 4 to 5 doses per vial. And this means we can vaccinate more people with less vaccine, which is important because there actually has been a limited supply of vaccine globally and in Australia. So all the jurisdictions have had to prioritise certain groups depending on how much vaccine they have and the amounts of people at risk that they believe they have in their jurisdiction. And ACT has recently secured additional supply of vaccines, which came in earlier this month. And so in response to that, we've also expanded our criteria, which I'll go through on the next slide. And I think it's important to note that despite the declining trends that I was talking about earlier, vaccination is still important ahead of summer and the World Pride events in Australia early next year. And additionally, with those events, it's still just a good reminder of the importance of opportunistic STI screening after the great talks that we've heard from Alex and Ingrid. So the current criteria for mpox vaccination are gay and bisexual men and other men who have sex with men who have multiple or casual sexual partners, as well as anyone who has sex with these men, regardless of gender. I think it's important to note that we are very closely monitoring the demand and supply of vaccines through regular meetings with our providers and external stakeholders. So the eligibility criteria may change depending on supply and demand, so important to stay updated. And likewise, the vaccination clinics may also be expanded in the future. So at the moment, because of those complexities with the eligibility criteria and the intradermal administration, it's only being provided through 3 clinics in Canberra, noting that Hobart Place General Practice only vaccinates people with Medicare cards, but the other 2 sites at Canberra Sexual Health Centre and Interchange vaccinate anyone. A referral isn't required. People can just call up and book to get an appointment. And just again, a reminder that Mpox is notifiable in the ACT. So if you see someone who has lesions which are consistent with Mpox infection and they have the epi risk factors like recent travel, or if they're a man who has sex with other men, then you should contact ACT Health, specifically the Communicable Disease Control Unit, to discuss the initial public health management, including testing. And here are some slides to the resources that I was talking about. The top one is the ACT Health Mpox webpage, which I think is the important page for the most up-to-date eligibility criteria, as well as the vaccination clinics. So thank you for your patience, and apologies for dropping out before.
That's great. Thanks very much, Therese. I think we've got time for one more question, and this one's for Alex. So Alex, the question is there a correlation between PrEP and an increase in gonorrhea and syphilis?
Yes, thanks. There is some evidence of that for men who have sex with men. So it highlights the importance of regular and frequent testing among that population, irrespective of PrEP use. But that doesn't explain the increase amongst women.
Okay, thanks. So I think we might wind it up there, everyone. So thank you all for attending. That was really useful. And thank you to the speakers again. And thanks, Therese. Sorry about the technical issues. So for attendees who are GPs and they want to get their CPD points, please complete the evaluation survey, and also please fill in your RAC GP number. And we'll be sending out all the slides to all the attendees after tonight. So thank you very much again. Good night.